with redundant skin, fat that is a little bit resistant to further diet or exercise strategies? Why do they seem to kind of all occur in the same area, but also in different areas between the sexes? So if we look at it from a more anatomical standpoint, we have two layers of subcutaneous fat, and those are separated by what's called a superficial fascial system. Now, that superficial fascial system is really important because it acts as a way to anchor the skin down. So when you are trying to pull on it, it doesn't tend to move. So the good examples of this are in the palm. So in the palm, it has a very superficial fascial layer, so the skin is really adherent at that level. And for that reason, when you try to move the skin in the palm, it doesn't move very well. And that's advantageous because if you're trying to pick up something and there was no adherence of the skin, your skin would just slip down, you would fall out of your hands. The difference is in the abdomen or in the upper extremities, that superficial fascial layer is deeper. So when you try to pull on that skin, it has a lot more wiggle room, it has a lot more areas to go. Now with weight gain, what we end up seeing is the adipose tissues or the fat cells underneath the skin, they get bigger. And as a result of that, the skin needs to accommodate. So the way the skin accommodates is by decreasing its elastin or the kind of the rubber band nature of the skin in order for those skin cells to repopulate and then become a new baseline norm. The problem we see with that is as we gain more weight, the elastin or those fibers become under more stress and they tend to fracture. But as we also get older, our likelihood of repairing that injury goes down. So it's more of a, once you've lost it, it's really hard to get it back. On top of that, we also start seeing the development of cellulite. And cellulite is a whole little unique entity that is a result of variations in the deposits of the fat in both that superficial and deep layer, and then tethering bands to the underlying muscular structures. So like I said, the elastin fibers, they end up fracturing or stretching, and this results in that kind of that saggy or the ptosis nature of the skin. Where we would see that is in the abdomen, in the breast, or in the buttock, as well as the inner thighs and outer thighs. On top of that, with the increasing age, we see a less and less return to your previous baseline with that degree of weight loss. And then BMI effects on kind of the overall appearance or areas of redundant and excess skin is related to the severity of the BMI drop. So if you're, and BMI is basically a body mass index, it's a way of looking at the overall surface area of an individual with their height and their weight, and putting that into a scale that then can be used as a reference amongst different individuals. So if you are going from a BMI of 50 down to 20, that's a significant weight loss. That's probably in and around a 200-pound weight loss. And you're going to see that individual's elasticity and fibers and redundant skin and excess is going to be different than someone who dropped their BMI by about 15 points. So again, why do we see physical characteristics in certain areas? And why do we sometimes see differences in males versus females? And this again goes back to those adherent zones. So you can imagine that an adherent zone is an anatomical area where the skin is really tethered down to the underlying muscle in a greater degree than the surrounding skin. So where we see that in females is, the great example is the lateral thigh, where we get adherent zones essentially here and above, which gives, I didn't name it, but that saddlebag type of deformity, where you have a low-lying soft tissue redundancy with skin excess and adipose deposits on the lateral thigh, where in men we usually see that in the love handle area, because our adherent zones are a little bit different. So Dr. Isser is going to talk about kind of the what is insured and what isn't.
Okay, so I know this is probably the part that a lot of people definitely want to know about. So every province is a little bit different in terms of what they will cover. But for the most part, the only thing that's covered is an abdominal paniculectomy. Prior approval is required and is only surgeon specific. So a lot of people will come to one of us and say, well, I got a prior approval from Dr. So-and-so, so everything's ready to go. I recently learned that isn't so. It's surgeon specific. So we will obviously apply again for a pannus removal for you. Essentially, most provinces will cover the pannus. There's usually not that much of a pushback from the provincial governments to cover it. But it has to be medically necessary. So rashes, skin breakdowns, ulcerations, recurrent intertrigo, which is recurrent yeast infections in that area. Unfortunately, due to the overwhelming costs in the healthcare system, the new governments have been very strict at the procedures they approve. And it's not only weight loss procedures, it's everything across the board, and we're feeling it because we're kind of caught in the middle of everything. At the end of the day, private insurance coverage that you may have through Blue Cross or through Great West Life, they may cover some surgeries, but definitely look at your riders that you have in your insurance policies. So what is abdominal pannus? So abdominal pannus is that lower part that overhangs the waistline. That is the area that if you were to pick up your abdomen, that's a loose overhanging tissue. Unfortunately, in some people that even have lost 100 to 200 pounds, they might not even have a pannus. And that really sucks at the end of the day from a cost perspective, because there's nothing that we can do to help you out with that. In Ontario, the rules are even stricter. So if there's anyone that's come from Ontario today, the rules are even stricter. It actually has to fall below the area of the pubic area. So they're a lot more stricter than Saskatchewan or Manitoba. What this is a functional operation. It results in improvement in hygiene, skin breakdown, ulcerations, and infections. It's performed independently or combination with a tummy tuck. It is a day surgery, which takes 1 to 2 hours to do, and the recovery is about 2 to 4 weeks.
So I'm gonna just start talking about kind of what are our options for all of the different areas where we can have this issue with skin excess and soft tissue redundancy. So there's some kind of basic goals or principles for body contouring. And the big one is really that what we are doing is we're going to be exchanging scars for redundant skin. The skin itself, unfortunately, with all that diet and weight loss, because of that loss of that skin elasticity, it doesn't bounce back quite the same. You can imagine it's like taking a balloon right out of the package, blowing it up for the birthday party, and after the party's done, and when you take the air out of the balloon, the balloon itself doesn't come and shrink down to the size it was originally in the package. It still retains some of that excess. So you really have to physically remove it. There aren't really any good conservative strategies or further exercise modalities or weight loss that's really going to take that extra skin away. You actually physically have to remove it. So we're exchanging all of that redundancy for scars. Where that comes into play or becomes important is, well, what do we do with these scars? So our goal is to try to hide as many as we can. And there are some areas that are obviously better than others. A low-lying scar in the abdomen is often hidden quite well in undergarments or bathing suits. This is an upper body lift, which would be a scar that would be hidden in a bra strap line in a female. But there are some scars that are a little bit more difficult to hide. Those would be surgical procedures in the upper or lower extremities for the soft tissue excess in the medial thigh and the medial upper arm, kind of respectively. And this is kind of an analogy on how to think about it. So the lampshade, it would be soft tissue redrape in an individual who has really good skin elasticity. The skin is tight and taut, and it's able to kind of hold its shape. Where in kind of that candle wax analogy, the elasticity isn't there. It's more moldable, it's more putty-like. So it's going to really have a strong effect on gravity. Gravity is going to pull on that area, and it's going to kind of collect it into groups, which gives you in the abdomen the overhanging apron of an abdominal pannus. So we're going to see these most often in the buttock, the face, and the breast. People always say, well, liposuction, I've heard great things about this. Do you think I would be a good candidate for it? Liposuction is a really great modality, but it's almost I like to call it like icing on a cake. So you're not going to really treat a lot of the body contouring issues just with liposuction alone. And you can actually make some of them worse. Because what you're treating with liposuction is bulk. You're not treating the skin excess, you're treating the bulk underneath the skin in terms of residual fat deposits. If you were to aggressively treat an area that has skin redundancy with liposuction, you're going to pull out even more of that fullness, which can make the overlying skin overhang more exaggerated and can actually make it worse. So what doesn't work? I mean, there's a list of things. If I had a way that I could say I can get skin tightening with zero surgery and zero downtime, I might not be here today. I might be, in a nice warm place, just sitting, stretching out. But there really isn't a good way to do it, at least not yet. And you'll find anything under the sun. Thankfully, this Lady Sauna Slimming Belt doesn't ship to Canada, so you don't have to worry about that one. But the other ones, they also don't really work all that well either. Body wraps and corsets, they have their place, but they don't treat anything. They're basically just, really compressing everything down and more shaping garment than any type of treatment modality. The hot and cold body sculpting devices, skin laser tightening, works to a degree, but the severity or the change just isn't worth the associated cost, most often with individuals who've lost a lot of weight. So we're really looking at surgical techniques. There's some small scar options. Those often are associated with just small results. Because really the problem is the excess, and you've got to remove it physically. So if you're not removing the excess, you're not really treating the area, you're just kind of just glazing over it. And then there's these thread lift procedures. They don't work all that great either. So the procedures, we'll touch base on kind of the common ones. Each person is their own kind of person. So they'll present differently. Some people will be great candidates for abdominoplasty. Some may need a little bit more, and that's when we get into the fuller extended versions, or even the fleur-de-lis abdominoplasty. Some people are interested in breast options, rejuvenation procedures. We have in our office here 2 great modalities that we kind of have championed. I'm a big fan of the dermal suspension auto-augmentation. Dr. Isler is kind of pioneering the work with using implant devices and internal bras, and we'll kind of touch base on kind of our different approaches to that. But it's really nice because it gives the patient options rather than just say, I only do it this one way, and if you don't like it the way I do it, then you can go see the next guy. You still can, but you don't have to go too far. It's just over there. Arm lifts, thigh lifts, buttock lifts, we'll kind of get into all of those things. Often individuals with substantial weight loss have more than just one issue. So what we like to do is try to work with you individually to make your problem list, and then work with the areas that you see you would like improvement on, and how can we combine them for both patient safety, for financial ease, and for recovery purposes. So those are our big 3. So we want to take into consideration the operative time. I did my fellowship training in Pittsburgh. There was not my fellowship director, but there was another individual who was doing what they were calling a full body lift, which was essentially every procedure that we named done all at once. Patients would wake up in ICU. They're often intubated. The procedures could be anywhere between 8 and 10 hours. I'd never done that. I would never do that. I think it's just unnecessarily risky for something that's elective. So you want to kind of balance how much can we get done in a safe amount of time with a recovery that would be manageable. Because what I don't want to do is put you in a position where you're like that bad skier in those ski movies that are in a full body cast, and you don't want to move for 2 weeks, because then it can increase your risk for some significant post-op complications. We also need to take each individual's medical health status and issues into consideration, because it's really important, and that's both to reduce risk and to increase recovery. Staging, because we want to group things, there'll be things that we won't be able to put into that group, and that's why we call it staging. So we pick the focus primarily, number 1, number 2 priority, sometimes number 3, and then leave the number 4, number 5 for a later date. And we like to usually split those up by about 3 months. It's really important to give yourself a little bit of time to heal. Like I said earlier, big incisions, big scars, big results. So you also have to heal all of those things. So you want to give yourself and your body time to kind of reset that balance. I like to do the medial thigh lift very, very last. It's, in my opinion, the one procedure that's kind of the hardest to get over, because it's an incision in the inside of your leg, which can be uncomfortable. And then when you're trying to mobilize your day-to-day activities, it's kind of like a constant reminder. So it's nice to kind of have gone through all of the other issues and hurdles, and then kind of save that one for last. Common combined procedures in the initial setting. Because of the Manitoba Health participation with paniculectomy, most individuals are seeking a belly option in terms of either a completion abdominoplasty or other truncal type of procedures. And the reason for that is the ability to piggyback Manitoba Health participation and coverage with the paniculectomy within that procedure to actually decrease the overall cost. So from a financial perspective, it's quite advantageous, but from a surgical perspective, it actually also is very advantageous, because you can think of the trunk as like the foundation of the house. Once you've set everything, you can then use that as a reference point to balance all of your other anatomical areas so that you get a really good proportional outcome. That would be included in a circumferential procedure, which is kind of marked here. The advantage of combined procedures, decrease the cost, like I said, less time off work, so it's less of an impact on your day-to-day life, and the decreased number of general anesthesia inductions, which comes with their own set of kind of issues. The disadvantages is just more demanding for the surgeon, but that I wouldn't say was a disadvantage. There's sometimes a lengthy recovery, and sometimes it's difficult to perform in solo at a peripheral hospital. Now, with us at first glance here, Dr. Isler and I and Dr. Brikacek, we all work quite well together. We actually are doing combined procedures. So in order to facilitate the ability to do as many anatomical areas at once while decreasing those surgical risks, we actually work together. So we both operate at the same time rather than just having one person.
So when someone's undergone massive weight loss, you have both horizontal and vertical laxity. And in some people, a traditional abdominoplasty, which addresses the vertical laxity, will be okay because there's that single incision along the bottom. But in patients that have undergone significant weight loss, and depending on age, you develop both that horizontal and vertical laxity. And the only way to get rid of that horizontal laxity is to unfortunately put a midline scar. And yes, it's not ideal because it's not hidden in an underwear crease, it's not hidden by clothing options, but it is dramatically effective. And this was a 67-year-old lady who underwent a fleur-de-lis abdominoplasty, and this is her 2 months after surgery. So obviously the scar is a little bit more red. Over time, they're gonna fade. The one thing that you can see is that it actually has an effect on the upper part of the thighs as well. And one of the things that a lot of people worry about when we do, even if we do a pannus alone, a lot of people worry about the pubic area. What about that? Are you going to lift that as well? And we do. We try to do that to as much as we possibly can. We understand what everyone's going through. We don't want to leave you with a nice tight tummy and then a bigger pubic area. It's all got to flow, and it all has to, just make sense to everybody involved. An extended full tummy tuck is typically the one if someone just has more vertical excess. Because of the amount of excess, we have to go beyond just a normal full tummy tuck. We actually have to go a little bit beyond, more towards kind of the flank area in order to get out that excess. Often what we'll do is we'll pull it out laterally to help minimize the amount of laxity that someone might get in the middle. The one thing I will tell you that a lot of patients are surprised about if they undergo these procedures is they're like, why do I have these love handles still? And the fact of the matter is it's actually not your love handles, it's actually your skeleton. So unfortunately, as you Most people were younger when they were heavier, and it expanded the skeleton. There's no way to accommodate that weight. So the ribs are kind of flared out, the pelvis is kind of widened, and when you lose that weight and you get rid of that skin all of a sudden, it's that underlying skeleton structure still there. What we don't know, and what would be interesting to see is, 20 years from now, is that skeleton going to come down to some degree? And maybe that's where those corsets and those binders come into play, but I'm not going to advocate for those at that point. I think there can be restrictive issues on your lungs and your bowels if you start to squeeze the skeleton down. So in terms of breast lift, there's a straightforward, breast lift with no implant. And what we're doing here, people just think that a breast lift is simply cutting out skin. And some surgeons do perform it that way. What we're essentially doing is, yes, we're removing the excess skin, getting the nipple and areola into a better position, but we're also reorientating the tissue underneath to make it more full and to provide that fullness, especially in the upper part of the breast, that is deflated and lost as someone loses weight. Now, Dr. Mitchell, he specializes in dermal suspension mastopexy, and I think this is a fantastic option, and so he's going to come and talk about that right now.
So this is really one of my favorite procedures. It's really nice because what it does is it captures that soft tissue excess or that tissue redundancy, and it puts it to good use. So instead of just physically remove it, what I do is I take out the lateral, kind of the redundancy at the lateral bra roll, which you can see here. So this is about a 55-year-old female who underwent a gastric bypass and then underwent about 100 to 125 pound weight loss. And she has that characteristic deformity that you would see with the breast. So, flattening of the upper pole, descent of the nipple areolar complex, widening of the breast mound, and then medialization of the nipples. So those are all of the issues that we're trying to address. She just wanted everything to be back as they were. So for her, this is a good way to avoid an implant and to basically get the same result by using your body's own tissue. So what I do is I use this skin excess out laterally and the excess medially, and I re-drape that into a breast mound. So essentially I make an implant out of your body's own tissue. And then I resuspend that up superiorly so that it holds the nipple into a more superior position and brings the breast mound up. So this is her kind of result. She's at about 6 months. And you can see that the nipple position is more superior. It's a little bit more lateral, more in keeping with the meridian or the midline of the breast. But we've also got a significant improvement in both projection, but we've also eliminated this lateral excess. So it's kind of like a two birds, one stone type of phenomenon. Now, Dr. Isser is actually really kind of pushing the barriers in terms of breast implant augmentation in the setting of a massive weight loss individual. This is relatively a new thing. He's going to come up and speak about it.
If you kind of historically jump back a little bit, breast implants and massive weight loss patients did not go along. It was fraught with complications, and the reason being is that when Dr. Mitchell spoke about that elastic fiber network is that crease along the bottom of the breast, whether it's in a male or a female. And what ends up happening is that at a heavier weight, that crease was taut. It was strong and it was there. And then as you've lost weight, like everything else, those ligaments have kind of dropped and they've sagged. And so they don't retract back. And so if you were to put an implant in there, it's going to drop because it has nothing to secure itself to. It has no crease or ligament to hold it in place. And so you don't hear a lot about breast augmentation being done with implants in the mass weight loss population. Using my background in cancer breast reconstruction, where those fibers and those ligaments have also been violated because the surgical oncologist has removed all of those ligaments and those barriers, we used to put what we call cadaveric skin in, or internal bra. It's cadaveric skin that comes from organ donors in the US. They've been fully vetted. There's no disease transmission. There's no DNA component left behind them. There's no medications anyone needs to go on. But what that does is act as a sling or a hammock for the implant. And what we do is we secure it typically to the bottom of the muscle, and we secure it down to where that crease is. And what happens is that it bears the weight. What we do know in patients who've undergone a lot of weight loss is the stretch marks. The stretch marks indicate to us that the elasticity in the skin is not there. Over time, gravity will have its effects again, especially if you add more weight with like an implant. With the internal bra, the cadaveric skin, that's not happening anymore. This lady's 5 years out. These are actually the largest set of implants that they manufacture, and she's doing quite well, and she's quite happy with that. If you're not looking for an augmentation with an implant route and you don't have that lateral breast tissue either, the other option that is your own is to put fat in there. So often if we're going to be doing a tummy tuck at the same time, or we know that in the future you may want a flank or a circumferential lift or a medial thigh lift, we can liposuck that area out. We process the fat down to purified fat, and then we can inject that into the breast. We are limited though to about a cup or 300 cc's. So in someone who's a 38 bandwidth, that's going to be about a cup and a half. For someone who's a 34, that's going to be 2 cup sizes. So that is another option that we can do.
So kind of back to the trunk. So this would be a torsoplasty or a bra line lift or an upper body lift. And this is a really great way to improve the contour of the soft tissue redundancy that's fallen on the back. And where you see these kind of creases, these are those adherent zones. So what you see is this little part of the skin is actually being tethered into position, and everything above it is being influenced by gravity and is being pulled over top, which is what gives you that crease. So what I do is just a little incision that goes along the back. We mark out where your bra is in order to make sure that it is within that space. And then we remove all of this segment here and pull everything up. So we're re-anchoring that adherent zone up more superiorly so that you get that contour improvement and correction in exchange for, again, a scar. Arm lift, or otherwise known as a brachioplasty, is really a patient-specific type of procedure. So not all arms look the same. Some people have soft tissue redundancy in the middle third, or the proximal third, or 2/3, or the whole extent of the upper arm. So this is a really good procedure in order to decrease the bulk. The soft tissue redundancy can be done in conjunction with liposuction at the same time. And there's 2 placements of the scar. One is on the inside of the arm in what we call the bicipital groove, which is kind of a nice little position of the scar. It's hidden when you're kind of in repose or in with your arms kind of down by your side. You can see it when you're waving to family and friends, but that's about it. The incision on the back of the arm, really great, really tight contour correction, just has the scar just a little bit more posterior than on the inside.
We're recognizing that there's a time limit that we want to keep people in the operating room, and because more and more patients are wanting to get more procedures done at one point, obviously safely, we've started combining all of our expertise, Dr. Brickachek, Dr. Mitchell, and myself, in the operating room at the same time. And what that's doing is minimizing the operating time. It's combining all of our expertise together, and it's allowing us to do more procedures safely at one point. And so this lady underwent a breast lift with implants, internal bra, fleur-de-lis abdominoplasty, and a full arm lift. A single surgeon, this would have taken probably about 8 hours. Okay, we can do this now probably about 4.5, so we can cut that time. That translates to a cost savings to the patient. And really, from a health perspective, you're out of the operating room a lot quicker, you recover quicker, and then you're combining expertise of each one of us. So this is something that we have the unique opportunity to do because the 3 of us are here to do this quite often. And that's her results 8 months later. The one thing I will point out, If you actually look at the top of her abdominal incision, that's quite a common area that sometimes needs to be revised under local anesthetic. Often those little minor local anesthetic things, that's not going to be a charge to any of you. That's just, it's something that we have to accept, that there's going to be unknowns that happen when the skin's being pulled in different vectors. And those are things that we'll just correct at no cost.